Good morning.
So before you start, let me just inform the students. We today have Dr. Vikram Kate with us, who is the professor of surgery at Jaipur, Pondicherry. He's done a lot of work on upper GI diseases, especially peptic ulcer and its complications in H. pylori, and he also has a fairly large experience with management of corrosive injuries of the upper GI tract. So it's good for you that today to discuss this particular case, we have Dr. Kate with us. So Ashish, please start.
Yes. Good morning, sir. So I'm continuing with the case, sir. So my patient is a 43 male who is a factory worker by occupation and is from Bikaner, Rajasthan. He presented to us with the chief complaints of inability to swallow his saliva for last 10 months with hoarseness of voice for the same duration. So patient presented with the alleged history of accidentally ingestion of toilet cleaner under alcohol influence around 10 months back. He took around 50 ml of alcohol, toilet cleaner and immediately spitted it out. He had mixed type of vomiting of around half a liter over a period of next 2 hours, with one episode of with history of one episode of blood tinged vomiting episode also of around 50 to 100 ml. He also history of throat and intestinal pain with the hoarseness of voice. However, there was no history of respiratory distress, coughing, severe abdominal pain, or abdominal distress. He was taken to a hospital in locality where he was admitted in ward. Initially, he was able to swallow saliva only due to the pain. So he was kept NPO and started on IV medications. His symptoms partially improved and he underwent an endoscopic examination next day. But as his symptoms tend to persist and he was only able to swallow saliva only, he underwent a open feeding gastrostomy after 10 days of hospitalization, and he was discharged after at the 14 days after post-operative day 4 following the feeding gastrostomy with an uneventful course after surgery. Subsequently, he had multiple hospitalizations. He also gave history of sessions of narrowing release in the ENT OPD around 6 times in the last 6 months or in 10 months. And he also gave history of an emergency tracheostomy around 4 months back for an episode. Following and the post tracheostomy, his vitals were stable, and he also had history of multiple transfusions. Presently, he presented with complaints of incident onset inability to swallow saliva with hoarseness of voice for last 10 months. He is on FJ feed for the same maintaining his weight. However, there is no history of nausea, vomiting, abdominal fullness, fever, altered bowel habits, hematemesis, melena, loss of appetite, and also there is no history of regurgitation, recurrent cough, or fever. On coming to past history, there is no history of any ICU stay. There is no history of any TB, asthma, or COPD, or no history of any psychiatric illness in past. However, he is a chronic alcoholic. He tends to consume around 200 to 300 ml alcohol per day for 10 years. And for the same duration, he's chronic smoker also. He used to consume at least 1 pack of cigarettes in a day. There is no history of any opioid addiction, and there is no history of diabetes, hypertension, or hypothyroidism. There is no family history of any psychiatric illness also, and he is a father of 4 children with income of 5,000 rupees per month. There is no history of any drug abuse or allergy also. So to summarize, my patient is a 43-year-old male without any comorbidity and with a history of chronic alcoholism and smoking. He presented with alleged history of accidental ingestion of the toilet cleaner around 10 months back, and he required hospitalization and underwent endoscopy and open feeding gastrostomy around 10 months back. He subsequently underwent an emergent tracheostomy for respiratory distress around 4 months back, and also has a history of multiple sessions of stricture release over a period of 6 months. And now he presented with the absolute dysphagia with 6 with the hoarseness voice for last 10 months.
Thank you very much, Dr. Ashish. Now, what we'll do is you're given a summary. Instead of that, what we'll do, we'll run through the slides again, and I want you to interpret what has happened with the patient. Okay, so can you go to the first slide, please? Yeah. What points you have mentioned here? Now, the patient has ingested a corrosive. Now, from this slide, what information you get?
First thing is, sir, what type of corrosive he has ingested. What was the tendency to take the corrosive, and what amount of corrosive he has ingested, what was the contact time of the corrosive after the ingestion, and then after what was
No, I'm asking you, how will you interpret this? Like, what information, which is very important from
Okay,
this,
sir.
you gather from this particular slide?
He had toilet cleaners in India are mostly acidic in nature. So most
Okay.
likely he has inserted a acidic corrosive substance accidentally, and then after immediately he had spit it out, and subsequently he had symptoms due to that.
Okay, let me stop you here. If a person takes something accidentally, okay, around 50 ml what you've written, and he spits it out, how this information is of use to you as a treating clinician?
Accidentally, basically, patients who ingested the any type of poison substance, they tend to mostly they tend to consume larger amount because of they are ingested in accidentally in one go. But and that then after that is going to affect their esophageal and gastric systems more. But and also he had immediately split it out because this also tells us that he had no suicidal tendency in suicidal thinking also at that moment. So.
No, what point I'm trying to bring out, what you said is correct, that when a person takes accidentally, the person is not aware that it's a corrosive. The patient might swallow a substantial amount quite comfortably before the person realizes that it's a corrosive the person is taking, is it not? So, yes. As you said, that there is a possibility of substantial injury to the esophagus and stomach. Now, here we have slightly different history, that he has taken not a very large amount, 50 ml, and he's immediately, that word you have put, immediately spitted it out. So when something like this happens, okay, this is almost like something like a suicidal tendency, little hesitancy is there, okay? So even though it is accidental, but that point of hesitancy is coming out, he suddenly realized, is it not? He has suddenly realized that it is not something what he should take, and he's immediately spit it out. So when you have something like this, okay, I'll put my question more clearer. What sort of injury you expect in this type of patients?
Then I expect, sir, higher injuries and oropharyngeal injuries more.
Yes, good. So that is what you have to take the point from it. When a person swallows comfortably, there is a less likely that it could be a case of proximal oropharyngeal injuries, okay, oropharyngeal or even respiratory tract. But when a person spits it out, or there is a hesitancy, in those circumstances, what happens is most of the corrosive will come in contact with the upper tract, okay, upper GI tract or upper respiratory tract, and there is a high possibility that that area could be substantially injured. So that is what is the point I wanted to make through this. As far as little bleeding is concerned, little blood is concerned, that's not much of importance. Then throat pain, retrosternal pain, all these things will be there whenever a person takes corrosive. Can you go to the next slide? Now here, all right, what I wanted to ask you, his symptoms partially improved. He underwent endoscopic examination the next day, immediately following the ingestion of corrosive. So do you think that was appropriate timing for endoscopy?
Yes, sir. That is appropriate timing.
Okay.
Endoscopic examinations are in corrosive recommended in 24 to.
Yes. So it was appropriate timing, is it not? Now, why it should be done during that time?
Sir, because the ingested acid actually makes a coagulum in the esophagus, in the area of injury, and that time is actually phase of acute necrosis only, and that coagulum is actually making a barrier so that even after we insufflate with a minimal air, we will be doing very minimal injury.
Yeah, usually, in short, the answer is that transmural injury is little less likely in the first 24 to 48 hours. So less likely perforation. It's the perforation we are worried, is it not?
Yes,
so that is less likely. The more you delay beyond 48 hours, there is high chance. Then if you have to do endoscopy, you have to do after many days. Okay, so not like that. So this was correctly done within first 24 hours. Within 24 hours, next day itself, is it?
Yes, sir.
Now, when you do an endoscopy for the next day, whatever maybe the injury the patient has sustained, do you think that it is not possible to carry out an endoscopy completely? Endoscope will go inside.
Sir, I don't.
Why it should not go?
I didn't actually listen the question, sir. If you can.
Okay, I'll repeat the question.
Yes, sir.
I wanted to know the endoscopic examination finding here, if it is available, because it is not possible that the endoscope will not go through the upper esophageal tract.
Yes, sir.
Very less likely, because whatever type of injury is there, within 24 hours, it will not become so bad that you cannot pass the scope through it.
Yes, sir. Yes, sir.
So you can assess the injury very well. So what was the finding here? Because the next step, what you have said is that the patient was not able to swallow saliva. You have written here only on the top.
Yes, sir.
Okay. So that is again unlikely, because how it can produce a block within 24 hours? Is it not? So I wanted to know what was the finding here. It is not mentioned.
Sir.
Sorry to interrupt. We also have Dr. Saraswat with us. So I request him also to make a comment on this endoscopy.
Yes. Yeah.
Yes.
That I another pretty. I think I must be. Sir, that is an PPT. I just shared it.
Yeah. I think Dr. Saraswat is making comment. We can take his input on the case.
Am I audible now? Can you hear me, Dr. Karthik?
इधर आ जाइए.
Yeah. It's little. The volume is a little less, but we can hear you.
Right. No, I think the point you made about doing the endoscopy in the first 24 hours is quite right. If it has to be done, it has to first 24 to 36 hours. And the points you've made that there is unlikely to be a free perforation at that point that early. So, but we basically do it to grade the severity of mucosal injury. And I think the Zargar classification and the Chandigarh group have given good endoscopic descriptions of the findings. And they try to differentiate between acid and alkali injury. Acid often causes the coagulative necrosis and the so-called eschar formation very prominently, whereas alkaline injury, or that is with the lye or corrosives due to alkaline corrosives, you often have less prominent mucosal injury, but often it can be full thickness injury. So the point is that endoscopic injury should be done in the first assessment, should be done in the first 24 hours. And based on that, we have this classification system of grade 1 to grade 4, which I'm sure Dr. would be familiar with. The resident should be telling us the reports and the grading of the esophageal injury.
Thank you very much, Dr. Saraswat. So now it has been put, this is the endoscopic finding on that day. Diffuse mucosal injury of the esophagus, stomach reducing capacity, edematous folds, and pyloric narrowing is there. Scope could not pass through D1, D2. All right. So that is why I said when the scope could pass, the saliva also can pass, is it not? So it's not possible that the patient is not able to swallow the saliva. So this is what it is. Now, how do you interpret this finding?
So there is the mucosal injuries with or without exudate are considered to be grade 2A injury, but I will interpret in terms of grade and extent of injury. So it's involved in the entire esophagus. So it's very extensive injury, and the grade will be grade 1 to grade 2A. And stomach is also injured in the process, and it's having reduction in the capacity with the involvement of the entire stomach. With
so sorry to interrupt. This is the endoscopy the next day, no? Is it not? The findings are the next day.
Yes, sir.
Okay. So what is the most important thing you will derive from this? And if you reflect back on history, then you have to change the history. What you have to do.
Yeah, absolutely. The amount of
The extent of injury.
No, see here, the extent of injuries to the whole esophagus and practically the whole stomach, is it not? See, stomach reduced in capacity. Okay, I'm not very sure whether that sort of finding we may get in the first 24 hours, but it shows that. And then edematous folds and pyloric necrosis. Practically the whole of the esophagus and the stomach is involved. So do you think the person who has taken 40-50 ml and immediately spitted it out, okay, spitted it out. Once it goes to the esophagus and stomach, you cannot spit it out, is it not? So it is irreversible. So the history should be that the patient has consumed. That's why I said when it is accidental, it is very, very unlikely. I said earlier that I don't know how he realized it so quickly and he spitted it out. That will only happen in suicidal tendencies. So here what has happened is the patient has comfortably swallowed 50-60 ml and it has gone inside. So it has not only, and partly the patient, maybe I don't know, the extra sip the patient was going to take, that the patient has spitted out. So there is a possibility of injury to the upper tract also, the proximal tract also, and the endoscopy shows that there is an injury to the esophageal and the stomach also. Substantial injury is there. Okay, diffuse mucous injury, it's not very clear. Diffuse mucous injury, you cannot grade out very clearly what sort of injury is there because it's physically incomplete there. Yeah, we don't know whether ulceration was there, edema was there. All those things also might be seen there. So stomach again reducing capacity, edematous folds only it's written, pyloric narrowing. You will find redness, sometimes you'll find erythema, you'll find ulceration. All those things also will happen in first 24 hours.
Yes.
So those things are not visible here. Okay, that is what is the classification about. So, but still we have this much information indicating that the patient has taken substantial. Okay, so it's not that the patient has spitted it. Can you go back to that slide again?
The other point I would like to add is that when you said presenting complaints, you only mentioned, I think, the first slide, the very first slide, number two, slide number 2. Before this. Yeah. So you said inability to swallow saliva and hoarseness of voice for 10 months. If you just say this, some of the examiners have a kind of practice that they interrupt you at this stage. And then based on this presenting complaint, the suspicion would be of a malignancy. So you have to say following ingestion of accidental ingestion of a corrosive. It should come in the presenting complaint only, because that puts the symptoms in the right perspective. This is what I said about post-cholecystectomy problems also. If you don't mention cholecystectomy in the presenting complaint, the whole scenario looks different. Yeah, please carry on.
So that is what was the finding I was looking for. You had that finding, okay. And then he underwent open feeding jejunostomy after 10 days. Why do you think he underwent after 10 days?
So because initially, maybe because the treating physician may have tried for a conservative management, considering
In the form of?
In form of allowing keeping patient NPO and subsequently allowing him to have some oral liquids. But as patient was not able to tolerate the liquids in subsequent days, they went for the open feeding jejunostomy.
Yes, that is what is very highly possible, that they must have given a trial, at least on the endoscopic finding. Looks like they thought that maybe we can give a trial and see whether the patient can take orally. Patient was not able to take, so they have done a feeding jejunostomy. Okay.
Yes.
So, and then he was discharged after that from the hospital. Can you go to the next slide? Okay. How do you interpret the first 2 lines?
Sir, he has history of multiple hospitalizations in form of multiple sessions of narrowing release. What he told me, okay, there was a narrowing as the ENT OPD it was told to him, and they were trying to narrow the release in the ENT OPD. So we can interpret it like this: most likely he's having a very high stricture, high corrosive stricture, and they were trying to do the alveolysis in the ENT OPD so that they can see the lumen or the opening of the lumen in the esophagus.
Yeah, so it's not high stricture that we cannot make out from this. It indicates that there's stricture at the proximal. The patient might have the whole esophagus strictured. How do we know that? Is it not? It might be there. Stomach also might be strictured, so we don't know that. But it very clearly indicates when we send the patient to ENT OPD for the release that the patient has got substantial oropharyngeal injury, that area. Okay, a lot of synechia will form. Okay, and that is what will happen when you have this sort of presentation. Now, this patient has got one unusual symptom. What is that?
Hoarseness of voice, sir.
Very good. Hoarseness of voice. Why?
Most likely the accident, the acidic ingestion has injured the vocal cords.
Yes, it is because of vocal cord, because it cannot injure the recurrent laryngitis, is it not? It's unlikely. So it is because of the injury to the vocal cords that must have happened because of the proximal injury. As I said, oropharyngeal, and then there is a respiratory tract. When the patient spits out, that is what is the danger of spitting out. Okay, actually a patient comfortably takes the what do you call this, corrosives, okay? And then sometimes the injury, this proximal injury is less likely to happen. So here, both the things have happened. Patient has taken also, and I think the next step, the patient has spit it out. So because of the injury to the vocal cords, there is a likelihood of hoarseness, and the next slide tells that. Okay, because injury to the vocal cords is there is a narrowing. Is it? But tracheal injury is also there, and they had to resort to tracheostomy. Now, with this information, patient had emergency tracheostomy 4 months back. How this information will be of use to you when you consider further management?
So maybe there was a oropharyngeal stricture which was partial in nature initially, and there was and is subsequently progressed during the through a period of 4 months, and then after patient had sore respiratory distress that it,
Just let me interrupt you. Professor Kapoor, I wanted to ask you, the question is to be directed only to one person, or it can be kept open so that others can answer in the chat?
We let them make a comment or answer later, otherwise it becomes difficult.
Okay,
so
fine.
We continue
fine.
with Ashish only.
One person. Okay, fine. Thank you. Yeah.
And whenever he cannot answer, then since this is a teaching exercise, we provide the answer.
Okay. Yes, Dr. Ashish, can you continue? What is the most important information you get from this particular point?
So, sir, most likely, as you asked for tracheostomy, sir, most likely patient had some oropharyngeal injury in the initiation.
No, that's understood. That you already told. But more important than that, tracheostomy is done for that only, no? Is it not?
Yes, sir. So that
If this history is present.
Laryngeal inlet also. The injury is involving the laryngeal inlet also. And now
that is fine. That's fine. That is why the thing has been done. So I asked you very particularly that when it comes to management, how this point will help you.
Sir, so management, if the laryngeal inlet is involved and the patient has been on tracheostomy, then I have to consider it for the adherolysis first, if possible, in the laryngeal area, or it also tells me that there is a very high stricture in the esophageal inlet also. So maybe patient may require a pharyngocoloplasty in feature, permanent.
Very good. That is what is the important point I wanted to make, that when the patient has injury to the laryngeal apparatus or the vocal cords, it is easy to make a decision to do pharyngocoloplasty. When we go ahead, we'll find out how to treat high pharyngeal strictures. Okay, high pharyngeal strictures are not always treated by pharyngocoloplasty.
Yes, sir.
Okay, there are other options. You must have seen our papers where we have given other options. We rarely used to do that. Okay, so but when something like this is there, it makes the decision easier, and you prefer to do this. Why?
Because the injury is very high, and when we are doing pharyngocoloplasty, we give patient to have an option of permanent tracheostomy throughout the life. But in this, the patient is already having a tracheostomy, and inlet is laryngeal inlet is already closed, so it's easier. There is no risk of aspiration.
Aspiration, yes, that is what is the problem of pharyngocoloplasty. That is why, as far as possible, you should do a esophageal anastomosis and not to the pharynx.
Yes,
if you can generate or you can produce a new esophagus, try to anastomose to that. But when the trachea is involved, okay, you have a tracheostomy, then that risk is not there. The risk is problem is always aspiration. It's not easy.
yes.
Okay, when you have this pharyngocoloplasty, you have to teach, or then they might have this problem again and again, whatever way you do. So that is why when you have this sort of history present, it makes a later decision easier. Okay, and of course, what you already told, that it indicates that there is a proximal injury and to the oropharynx and to the respiratory tract. Okay, fine.
Students, please note that for every question, there is a key word in the answer. Now, in this, when you were talking of pharyngocoloplasty, the word Dr. Kate was waiting to hear from you was aspiration. The moment you said that, he responded positively. So for every question, you should know the keywords. They must come in your answer.
Thank you very much, Professor Kapoor. Anything unusual there in this? Anything else? This is not routine. The last line, I will give you a hint on it.
The multiple history of multiple transfusions is there.
Yes. Actually, you should write blood transfusions. Okay, that's what you mean, no?
Yes, sir. Yes.
It should be very clear. Yeah. So why? Is it common to have this?
Basically, multiple.
It is not. Okay, I'll tell you the answer. It is not. Tell me why. Multiple transfusions are very rarely required in general. So you are telling before surgery, no? Is it not? Whatever has been, we don't know whether surgery has been done or not, but why in between the patient, while waiting period, why the patient should have transfusions?
So, there is a possibility of having if the patient is having a injury in esophagus and pylorus both, there is a possibility that patient may have stress ulcers in the stomach also, which
No, that is very unlikely. That doesn't happen. Stress ulcers and corrosive and all is not described at all. Any other reason? See, when something like this happens, immediately something should click, as Professor Kapoor has mentioned, when these points are given. That is why I did not ask you to only see the condensed history, what you mentioned.
There may be some fistula.
No, again, I'll give you a hint. Okay. Now see, a patient who usually will ingest corrosives in general, okay, as Professor Kapoor mentioned earlier, that you did not mention following corrosive injury. If it's the case of carcinoma esophagus, things are bad. Patient might have anemia to present with. Most of them have anemia, CA esophagus, CA stomach, is it not? So, because of malnutrition. But here what has happened is that the patient, usually healthy patient only will take all these things. The patient is asymptomatic and the patient is not a patient before taking the corrosive. So that we presume that time the hemoglobin, everything should be fine on the patient. And this is not for years together. It's only 10 months history here. So the patient has taken corrosive, let's presume the hemoglobin is fine before that. Is it not? He's a male patient, no? Is it not? That's what you said. So male patients, otherwise also the hemoglobin most of the times will be good. So he has taken the corrosive, ingested, 10 months history is there. Patient was put on FJ, just 10 days later following the corrosive. Now the patient has anemia. That is why transfusion must have been given. So why? I've given you now the expanded version of what has happened.
Having iron deficiency anemia, sir, because
no, the patient is not probably using the feeding jejunostomy properly. Okay.
Yes,
that is the reason. Okay. Sometimes what happens is it is done, and then if they are not properly trained or they have some other reasons for not taking those jejunostomy feeds, then slowly the patient will go down. Okay. So when in history, when you do examination in history of this patient, something else you would like to check from the notes what the patient has bought, what you like to check to indicate that there is a possibility of malnutrition.
His either whether he had weight gain or not.
No, weight gain nobody will get. Okay, so the weight, usually the weight.
Weight.
Yes, weight gain also something should be there with jejunostomy. Not much will be there, but weight fall should not be there. Okay,
maintaining
so,
weight.
Yeah, if the patient is not maintaining weight in those circumstances, what will happen is that that the patient might have anemia also, and then the patient might be requiring multiple transfusions. So, how this point is of use to you from management point of view?
The patient is it appears to be that patient is severely malnourished, and he needs the counseling for the proper FJ feeding so that we can optimize his overall body buildup for the future surgery.
So you cannot operate on the patient, is it not?
Yeah, immediately we can't operate.
You cannot operate, even if it is 10. Is 10 months suitable for suitable duration for surgery in a patient with suspected corrosive stricture following injury?
In view of having a very high stricture, I'll wait for.
No. See, I'm asking very specific question. Okay, it's a leading question. So I'll repeat the question. That patient has 10 months history of ingestion of corrosive. You're diagnosing the case of corrosive stricture. Is the patient in a suitable period to be considered for surgery? Everything is fine.
He's within one of the suitable periods.
Yes, is it not? More than 6 months usually.
More than 6 months.
So he fits into that.
Yes,
but if the patient is malnourished, can you operate? It's a major surgery.
No,
Can't. So this point again, as I said, is unusual. Multiple transfusions. Yes, is usually not required. Okay, and as you said, patients rarely bleed from this. So again, we have to see whether the patient is not taking from the if the jejunostomy fields are not adequate, naturally the patient will go down. Is it not? Patient cannot swallow anything. So feeding has to be from that source only. So weight has to be checked properly. The weight is not proper. Okay, the BMI is very low for the patient. In those circumstances, you will have to defer surgery. You can always defer surgery for any length of time. Is it not? Patient is on FJ. If the patient can be there for 10 months on FJ, another 6 months of the patient can be on FJ. Okay, the patient has to properly train and taught for this. This is very extremely important. There is a underprepared patient, not properly selected patients. You are likely to invite complications following surgery. Okay. So anemia and hyperproteinemia, these are two important things you like to see in this patient. Yes. So fine. So when you look at the investigation, you are supposed to see that. Okay. So do you have information on that from the history, from the notes?
No, sir, I didn't have that information.
Okay, fine. Proceed. this is the present status of the patient.
Yes,
Is
sir.
it not? So that's fine.
So this is the summary. And this is the past history.
Okay, that's fine. That's fine. That's fine. It's all fine. This is what we have discussed now. So the next slide.
So coming to the general examination, patient was well oriented about time, place, and person. He is poorly nourished with the temporal following present. There is weight loss of his weight was 45 kg with BMI 15.6 square. His vitals were stable and he was.
So BMI is low, is it not?
It's
6.
BMI is low.
So he must be a tall person. Is it 45 weight is not bad,
Yes, sir.
but vitals must be more. Okay, fine.
And he was maintaining his oxygen saturation 90%. Room air tracheostomy. His
Just a minute. I think some mics are on. Can it be muted because there's some disturbance? The central.
Sir, they have muted Vikram.
I'm doing it. I'm doing it. Carry on. Ashish, you please carry on.
And his elusive performance score was 2. They were present. However, there was no pedal edema or cyanosis. On oral examination, dental caries were present. Mouth movement was present, including was well, including the protrusion. There was no visible mucosal lesion or cheilitis. On chest examination, the tracheostomy was present of 7.5 French, which was uncuffed, and the bilateral chest movement was present. On palpation, the chest movements were normal and simultaneous. The trachea was in midline, and on consultation, bilateral minimal post preparations were present in the bilateral lobes. On abdominal examination, the abdomen was scaphoid with a midline surgical scar in the epigastrium, which had healing by primary intention, and there was FJ in the left side of umbilicus. And on palpation, the temperature of the abdomen was normal. It was non-tender. There was no organomegaly or no palpable mass. The liver span was 12 centimeter. On auscultation, the bruit was present. No bruit was present. All stones were present. On PR examination, the anal tone was normal, and the fecal string was present over the glove.
Palpable mass means what? You look for some mass. This sort of patient, corrosive injury. What mass will you suspect?
I'm not suspecting any mass, but there may be fullness in the epigastrium in form of a distended stomach, maybe there in a patient.
No, let's say there is a mass. What could be a cause of that mass? In this sort of patient, that can happen. Since you mentioned it, I'm asking that point. It's very rare, but it can happen. What is it called as? Which will lead to a mass formation in the epigastric region. What is a gastrocele? Gastrocele.
Gastrocele is, I'm not aware of.
When you have fibrosis, okay, proximal fibrosis and distal fibrosis. So here you see the injury was to the esophagus as well as to the stomach. So if you have a lower end stricture of the esophagus and you have a pyloric stricture, very likely, there's a pylorus was narrow, first endoscopy itself. So if it gets blocked on both sides, you can have a gastrocele. Okay, so very rare condition, but since you mentioned about a mass, then you should know what you're looking for. Is it not? Otherwise, you don't get a hepatosplenomegaly, anything. You don't have to expect that sort of thing in this sort of patient. Is it not? So essentially, the abdominal examination in these sort of patients will be normal. So what you have found it. So proceed.
So to summarize the general examination, patient is poorly nourished with BMI of 15.6. He is tracheostomized. On oral examination, dental caries were present. On chest examination, bilateral post preparations were present. On abdominal examination, there was a healthy midline scar in a scaphoid abdomen with the FG in situ. So,
fine. Yeah. Professor Kapoor, Professor Saraswat, any questions anybody would like to put forth to Natasha?
I think we can move on to investigations and management.
Fine. Okay. So, Natasha, proceed. What will you do?
Okay, sir. So I'll first try to review the old reports, sir, of the patient.
Okay. This we already seen. All right. Anything else is there?
Then after he had multiple 90-degree endoscopies which were done in the ENT OPD.
So what is the interpretation of all this? Can you summarize it?
So the interpretation is there is a severe oropharyngeal injury with involvement of laryngeal inlet, and also the esophageal inlet is also completely restricted. There is complete
Blocked.
restriction.
Not able to enter.
Yes.
Okay. All right. As expected. That's what you said. So there's a substantial injury to the upper respiratory tract and this. Anywhere have they mentioned about epiglottis?
Yes, sir. They have mentioned about the pharyngeal epiglottic structure in the right side.
Epiglottis completely obscures the view of the endolarynx, is it not? Because that is what will get injured. Okay, in this sort of thing, it will become fibrous and it will close the inlet.
Close the
So
inlet.
it's becoming very difficult. Okay, so that is what is mentioned there.
Yep.
And of course, the esophagus, you cannot enter the cricopharynx. Okay, it looks like that. You can't see written anywhere, but must be like that. So, fine. So the next.
Next, I have the.
Yeah, don't have to repeat everything here. You just you interpret. Okay, the next slide interpretation. Yeah.
So
What are the important things you'd like to see here?
He's having anemia, hemoglobin is 9.3, and his albumin is around 2.5, so he's smallish also. But the rest of the findings are good.
So hemoglobin is slightly low, okay, 9.5. But as you said, the patient has received transfusions, so we do not know
That's why he's having.
how much was it. Yeah. So overall, otherwise everything is fine. Is it not? Fine. The next. The albumin level is there. Just see.
Yes, sir. Yeah.
How much? Where is it?
It's 2.5. It's low, sir.
2.5. It's low only. Is it not? So that's the problem. So albumin is low, definitely low. What is the normal albumin level?
The 3. We take a cutoff of 3.0 for the. And otherwise,
actually, book wise, it is 3.5. Is it?
3.5 is
but above 3, at least it should be there if you want to carry out some major surgery. But 2.5 is low. There's no doubt. Okay, fine. Then
non-patient for
again, there is a disturbance. A lot of disturbance is there. This mic is again on. Okay, carry on.
So when OGS was planned, that was not possible as patient was.
Yeah, it's unlikely. No? This sort of thing, very unlikely. That
upper GI endoscopy was.
just a minute. I think that person's mic has to be switched off. Dr. Bashir.
Yeah, please carry on.
Yeah.
This is the upper GI endoscopy I had from the history that there was narrowing below the epiglottis. That could not be identified. There was a hyperphagia. These are
Okay. As expected, the previous endoscopy, also the ENT examination also showed similar findings. So the respiratory tract is which is injured substantially, and there is a substantial injury to the upper oropharyngeal injury. Fine. So what next?
So, Dr. Kate, this would classify as a pharyngeal stricture?
Yeah, pharyngeal stricture. Definitely.
pharyngeal stricture. So now it's 10 months. So we will first admit the patient for the optimization of his nutrition. So we'll counsel him about the FJ.
No, how will you optimize the nutrition by admitting?
We will counsel him, sir, for FJ feed, sir.
Yeah, counsel him better, is it not? Because the 2.5 to become 3 plus will take time, is it not? So I think that better we have to give some more time and make sure that his hemoglobin also improvises on its own, and then this also improvises. So that might take, there is no point immediately rushing into it, the surgery. There's no indication for surgery immediately.
Yes, sir.
So we wait for another 4 to 6 weeks, properly optimize, make sure that the patient knows what should be taken, how it should be taken. And let's say now the albumin is 3.3, patient has come to you, okay? And hemoglobin is, let's say, 10.5 or 11. So
any other point in preparation? Any other problem he has which you have overlooked so far? You described it, but you are not mentioning it now. Test.
हाँ, chest, he has
You said he has bilateral forced crepitations, which
हाँ, sir.
means at some point he has aspirated in spite
Aspirated.
of a tracheostomy.
Yes, sir.
He has aspirated. So you need to take care of that also, isn't it?
Yes, sir.
Please carry on.
So now the 3.5 and HB is 10.5. So
Yeah, and his chest is clear now.
yeah,
Okay.
chest is also clear. So
Yeah.
he is well optimized. So now we will admit the patient and evaluate further. So first I will do the routine investigations for the pre-operative checkup. Also chest X-ray, and then after doing ENT opinion for the again the pre-op evaluation of the laryngeal inlet and all the
Documentation you can see.
But
Okay, because so many
once
times
you have
patient has been seen.
once you have a tracheostomy, why are you worried about laryngeal inlet? How does it matter?
Sir, because the last endoscopy showed there was a partial opening in the laryngeal inlet through which he was able to speak. He is having hoarseness of voice. So suppose we do a pharyngocoloplasty and subsequently we see that he is having aspiration through that inlet. So it's better to document is whether now the inlet is closed or not, sir.
Dr. Kate, your views on this?
Yeah, I think it's not very important because I'm not very sure what you are meaning, Ashish, that when you say that a little aspiration can happen. Tracheostomy is there. So where's the question of aspiration? So even if the inlet is a little bit partially open,
Okay, sir.
so how it lead to aspiration unless and until you are planning to decannulate later? Okay, so do you think that something like that can happen in this patient? Unlikely, no? Is it not?
Unlikely.
This sort of injury.
No.
So once you have a tracheostomy down,
Okay, sir.
when we make a tracheostomy, and let's say it's not a patient of corrosive, but some other place, we don't bother about aspiration because the respiratory system gets connected to the exterior directly. With nothing to be, even if the patient swallows, nothing will happen. Okay, so that may not be important, but as you said, definite documentation before you're planning surgery, you should have the findings, current findings. So you have a ENT present this thing, and see, when you do research, when you do studies, you have to have documentation from these papers and all will come from this information. So you do that. Is there any role for a CT?
Yes, sir. There is a role for CT. We will.
What is the role for CT?
So we will evaluate the status of the esophagus and the stomach via the CT. So
what evaluation?
So we will try to see the lumen of the cervical esophagus, whether it's patent or not. If there is an air column present in the cervical.
Suppose if it is present, then what?
Then, sir, we have to manage. Then the management is very different. We will plan patient for a neck exploration and from the right side, and to open the lumen of the cervical esophagus to get, and then after we try to get a patency from the pharynx.
No, this I know you are talking this from a paper only, but what I'm saying is that if you read the paper carefully, that is only done when the larynx is not injured. Is it not? Because if the larynx is not injured, as I mentioned earlier, you would like to avoid doing the pharyngocoloplasty and you would like to do a esophagocoloplasty so that the risk of aspiration is low. But once the larynx is destroyed, okay, do you think all those procedures you'll do, it will take another, that creating a lumen takes 1 year?
1 year, at least 1 year.
So then is there any use? Because what is the point in creating anastomosing to the esophagus or the pharynx when the larynx is gone? Okay, there's no risk of aspiration once you have permanent tracheostomy. So that air column thing will not work in this particular patient. That will be useful to see if the patient has manageable injury to this. Even if you're done a tracheostomy, you know this is likely to be temporary and you're going to decannulate. So then you should do it. Okay, what you say. Anything else you'd like to see on CT?
So I would like to see the vascularity of colon and the stomach also.
That is okay.
I'm going to use it. So
as far as status of injury is concerned.
Yes.
Would you like to see the stomach?
Yes, sir. As I mentioned, I would like to see the stomach.
No, what in the stomach? You're not mentioning. You just said I'd like to see the stomach, but what?
So vascularity and the contour of the stomach, whether it's normal, it's
no,
not.
No, vascularity. What will happen to the stomach?
Yes, sir.
It's not very important.
It's not contracted, so basically. It's
yes, that is what is important. How that will change the management?
Because if it's contracted, then I have to do a colonoscopy, sir.
Gastrostomy. Make a decision. Very high possibility is there. Instead of finding it on table that the stomach is contracted and gone, you try to do that. Okay. Although there was an injury to the stomach, early assessment said, but that was only within 24 hours. After that, we have not seen the stomach at all.
Yes,
So let's suppose it was a superficial injury that time. It only showed mucosal folds and stomach is perfectly fine.
yes, sir.
In those circumstances, you can consider doing an anastomosis to the stomach. Why bypass the stomach when stomach is fine? Is it not? So you can get a reasonable this. Any other investigation can tell you that the stomach is nice, distensible, and there is
Dr.
yeah.
Dr. Saraswat wants to say something.
Yeah.
Very interesting and unusual problem, at least we haven't seen too many pharyngeal injuries in our gastroenterology experience. The question that I had was, you have noted a very small, narrow opening from the pharynx to the distal portion where you can see the vocal cord, but not the esophageal inlet. So is it not possible to cannulate the esophageal inlet under fluoroscopy using one of the standards cannulating and guide wires? And then visualizing the pharynx and the upper part of the esophagus. And similarly, once you get a wire across, there will be some experience with the use of Bougie dilatations to do pharyngeal dilatation as well, so that you can try and restore what is the lumen here if you're able to access the distal esophagus, apart from also ascertaining the severity of esophageal injury and what you've just pointed out, assessing the stomach, pylorus, etc. So a direct endoscopic or a contrast imaging of the esophagus using techniques in which you can actually simple, like ERCP cannula guide wires can be negotiated down into the esophagus from the pharynx, especially with the tracheostomy, with the, he has a vocal, I mean, his airway is protected because of the tracheostomy. So manipulations and dilatation in this area is much safer than otherwise, and one can make an attempt to see if the pharyngeal lumen can be restored to some extent. I mean, any experience, or what is your, experience with the endoscopic, the role of endoscopic management in this scenario?
Thank you very much, Professor Saraswat. Very pertinent comment. Dr. Ashish, what do you say on this?
I actually didn't understand. Sir, voice was actually.
Oh.
What Dr. Saraswat was saying,
Yes, sir.
that through that small opening in the pharynx, can we attempt an endoscopic or fluoroscopic dilatation and then evaluate the stomach, esophagus, and stomach?
So that opening was basically leading to larynx and the pulmonary system rather than the esophagus. As far as I remember from the 90-degree endoscopy, sir.
So once you get there, you can pass the cannula wire and under fluoroscopy with small amounts of contrast, identify the esophageal inlet and cross the trachopharynx. At least the attempt can be made. And if you're able to do that, then I think you have many other options available.
We will require a coagulation release of the inlet, esophageal inlet, and then after we require CT to see if
No, Dr. Ashish, the thing is, the point is that if we can get an opening there,
then we can dilate.
that's what I'm saying. You're saying that it's unlikely, but the thing is, it may happen, may not happen. But if it happens, then let's say that the esophagus is only part stricture in the upper part, and let's say the other part of the esophagus, again on the endoscopy, did not show much of injury to the esophagus. It's just sort of different injury.
Yes,
and esophagus is patent. Don't you think then it will make a difference?
Then we can use it. We can, of course, if we
that is the point. Yeah. So the thing is, try. I agree with you that when you do a CT, it will show a stricture esophagus. If long stricture is there, it may not be possible to do that thing, but we have to attempt and presume that it is completely strictured. The same thing as I told you for the stomach. That if you have a dilated stomach, and if you have just
sorry, Dr. Kate, I think we have only about 10 minutes, so maybe we can discuss the surgical management of such a high stricture.
Fine. So, Ashish, now what will you do in this patient?
So I'll do a colonic interposition with pharyngocoloplasty and
what route?
Sir?
What route?
Retrosternal colonic interposition with the pharyngocoloplasty And then in abdomen, sir, I'll see instead of stomach for pharyngo gastrostomy or pharyngojejunostomy with colocolic anastomosis and NFG.
Fine. So that is what is the option that you have. That in this patient it's easier because since the respiratory tract is destroyed, the thing is you can do a comfortable pharyngocoloplasty, and so it will be based on what vessel.
Sir, we do mostly mid transverse. We use only mid transverse colon mostly. So we
No, what vessel?
that will be based on the ascending branch of the left colic arteries.
Okay. So the thing is, because it's a long thing, you require a long segment here. It has to not go to the esophagus, it has to go to the pharynx. So most likely you'll have to ligate the middle colic, and it will be based on this. Okay.
Yes.
So the iliac colic part, you'll take it to the neck, and it will be based on this. And the lower part, as you said, okay, most likely there is a possibility the stomach also might be injured, strictured and fibrosed. So you'll do a jejunal anastomosis, is it not? Pharyngojejuno anastomosis. In case if the respiratory injury was not there, okay, in those circumstances, what will you do?
So then after I will, then I do a CT to see if there is an air column present in esophagus or not.
If it is present, then generate a neoesophagus, is it not? Subsequent dilatations through the right side.
Right side.
And then use the left side for doing a pharyngocoloplasty. Not pharyngo, it will be esophagocoloplasty. Is it? Esophagocoloplasty, it will not be anastomosis. How much of the esophagus is required, proximal esophagus, so that you can make a comfortable anastomosis?
At least 5
centimeters. Yes, 5 centimeters is required. Suppose you find a small lumen is there. Suppose lumen is there. That lumen is not dilatable to make it comfortable. What is the lumen that you require so that the patient will not have dysphagia?
So 12 mm, sir.
No, 14 plus. Okay, 14 millimeters plus. Okay. Usually it can go up to 18 is the good lumen, but 14 plus you should have. So to create that lumen, what are the options available?
Then we can do a mitral slab, sir. We can modify mitral slab from the right side of the neck exploration, and
okay,
we can use pectoralis major or sternocleidomastoid.
What is the role of pre-jejunal flap?
Pre-jejunal flap, sir, that can be used basically in case of lower strictures. Then we can do a follow jejunostomy, but in the upper esophageal strictures, mostly we can create a new esophagus via use of the microtis flap ones.
So these are the different options that are available, is it not? So that, as you said, if the lumen is dilatable, let's say that that the lumen is not so bad and you're using dilators, that's the first option you should do. Okay, with the help of dilators, if you can create a 5 centimeter esophagus, that's best. If that is not there, then you can consider doing some plastic surgery options. You do a sternocleidomastoid flap, or you can do a pectoralis major flap and create a neoesophagus there, and then do from the left side esophagocoloplasty. Okay, so that is what is the other option. And lastly, as I said, sometimes just 1 or 2 points on complications. Suppose you have done a esophagocoloplasty.
Before that, Dr. Kate,
yeah.
Before that, can you please tell students about this right colonic conduit using the part of the terminal ileum also and preserving the ileocecal wall?
I don't have much of experience on that, so we usually never preserve that wall.
So you're not fond of
no.
right
We usually use what he said only, like left colic and plus minus middle colic. Middle colic we don't always like it. Okay, we'll put a bulldog on that and take it up. And if the length is adequate in those circumstances, then we preserve the middle colic. But sometimes you find the length is not adequate and the patient can be managed with the sectioning of middle colic, section the middle colic. So it will be based on the left colic artery. Okay, so
for the sake of discussion in their exam, some examiner asks.
Definitely, you can take middle colic. The transverse colon based on middle colic. You can take the right colon based on right colic. As you're taking the left colon, you can take similarly the right colon. There are people who take the right colon and then they use. I'm not very sure what they do with the ileocecal wall, but they transfer and then instead of left colon, they use the right colon. Okay, so that is what is there.
Can you please elaborate a little more on this air column in the esophagus?
Yeah, basically what he meant by air column is that when patient is not able to swallow, but a small lumen could be there, which is not visualized on endoscopy also. And even when we try to do blind cannulations by those topitic guide wires, sometimes that also will not pick up the lumen. But the CT will show an air column in the upper part of the esophagus. So if air column is there, that means there is lumen there. So once lumen is there, we open the esophagus, explore the esophagus from the right side. We give a long hockey stick incision and open the esophagus on the right side, find out the lumen. Then once you have a lumen, let's say it is around 4-5 millimeters, you open the esophagus and then put a flap of the nearby myocutaneous flap, that is sternocleidomastoid, which is there only. So we reverse, the skin part will go as a mucosa, and we create a new esophagus. And then serially, then you have to do dilatations. You have to do esophagostomy there, and then create a new esophagus, and then do the coloplasty from the left side. So that is what is the use of doing when you have the air column. Definitely not useful in this patient because here the larynx is destroyed, so there's no point doing all this procedures. Then you can do straight away pharyngocoloplasty. So one of the things that is very important is the leak. Okay, that happens post surgery in the neck. So what is the commonest cause of that leak?
Sir, venous congestion mostly in the...
Yeah, because of the inlet.
Inlet.
So you have to make sure that the inlet is quite wide, properly open, especially when you create the retrosternal route. Okay, the thing is that we have a tendency to just create in such a manner that the colon should pass through. It should not be like that. The colon should pass through and it should be nicely, adequately pass through, and the mesocolon also should be very comfortable. Otherwise, what will happen? Venous congestion and then leak and all sorts of problems can happen. Okay, so once leak happens, it leads to stricture formation. Yes. Then again, the patient has come for dysphagia, and again you have created another dysphagia in the patient. So that is what is that's what the thing is. I think you have done a very good presentation and you covered most of the points, Dr. Ashish. So if any questions are there, maybe you can answer or I can answer. Yeah, you can put in the chat.
Any student who wants to ask anything? Malin, Krishna, you want to ask anything? Online students?
You can close this presentation. So that.
Any other faculty member would like to make any comment? Ajay, you want to say anything? Yeah, my colleague Dr. Ajay Sharma is here.
Morning, sir. I think it was a very good presentation and most elaborately discussed by senior person, Dr. Vikram.
Thank you. Thank you very much.
So, only thing is, why do you prefer always a retrosternal? Why not?
Actually, your voice is breaking.
Yeah, so Ajay wants to know about resection and using the posterior mediastinum. Actually, Dr. Saraswat also was, when we were coming, he was saying that what he was asking, what is the current literature and current concept about the risk of malignancy and role of resecting the corrosive injury. Ashish, maybe you can take that first, and then Dr. Kate can moderate.
The concept is basically when you do esophageal dissection, the people who support it, they say that the corrosive esophagus has the highest risk among all the risk factors for the malignancy, or we can say especially squamous cell carcinoma malignancy. But the opponent says that the risk of malignancy over a period of time, as been seen in many Indian studies also, is very less. It's around 1% to 2% only over a period of 30 years after corrosive injection. But the amount of morbidity that procedure has in case of a corrosive esophagus, the esophagus is very adherent to surrounding structures also, specifically thoracic structures also. So the esophagectomy is very morbid in these patients as compared to patients of carcinoma. So the morbidity is very high, and the advantage of doing esophagectomy to avoid the malignancy is very less, as risk of malignancy is very low. So that's why rather than doing esophagectomy, it's better to bypass the esophagus.
Yeah, I think he's answered it very well. I don't think he has left out any point. Very good. So I think that is what is the thing. But little opposing point I'll take here, although we don't resect, that people who are experts in doing esophagectomy, they might not find doing resection of the esophagus, ultimately the benign esophagus, so difficult. And shortest route is obviously, and the most physiological route we can say is the posterior mediastinum. That is where the esophagus lies. So they prefer doing a thing, but usually many times when that is used, many times, and again repeat, many of the people who do that, they use stomach as the conduit. So it becomes almost like a THE operation or Ingus procedure, that sort of thing, because stomach is spared and the esophagus is only injured, and then they create a tube of the stomach and take it up in the neck. So they didn't use many times the colon, but definitely that can be used, and it's a question of perspective. And both the options are open. But as you said, the person who's not that experienced in doing esophectomy, definitely that person should not consider doing, because as Dr. Ashish had mentioned, it is a difficult procedure, and it is like doing a Whipple's procedure in chronic pancreatitis, same way as compared to this. So you have a lot of fibrosis there. So when you have to do surgery in presence of fibrosis, it becomes difficult. So that's how it is.
But most esophageal surgeons have now come to kind of believe that the risk of malignancy is not very high. Is that
Not
true?
very high. Yeah, definitely not very high, and retrosternal route is good, and don't have to again, because here you have to do esophectomy, and following that you have to again do mobilization of colon and bypass. So in a patient who's already morbid, we can see here the borderline, this thing, the albumin is already 2.5, and we might bring it to at the most 3.2. So doing an additional procedure may not warrant that advantage. If you see a risk and complication, so the risk is more compared to this complication.
So I think I will have a slight differing opinion on that. Maybe we don't have a very wide experience on this. We have hardly have 12 patients with coloplasty and colon being used. And out of these 12 patients, we had 4 patients and we used the retrosternal route, which had created a problem and swallowing in these patients. I don't know whether it was the retrosternal route that was causing the problem. So subsequently, we again went back to the natural route, and then we found that actually these patients who are having a natural route of colon being used, they fare better. So I don't know whether this is true always, but since you have a wider experience, you can elaborate on that. Do you have any problem in dysphagia or motility?
What sort of anastomosis you are doing? Is it side to side or end to side?
End to end.
No, I mean end to side. Usually it will be side of the colon. No, better to do side to side anastomosis. Should not do end to side. We used to do end to side very in the early phases of the thing. Okay, so we stopped doing that. You don't have to do sectioning of the esophagus. If you do end to side, also the risk is that you're closing the lower end of the esophagus. Theoretical possibility is there of esophagocelia. So it is always better that make a side cut on the esophagus and anastomosis.
No, but when you are putting the conduit in the posterior mediastinum, then you are doing an esophagectomy.
No, I was meaning that when we go, we practically never do esophectomy. So
okay.
Retrosternal route we go, we have the esophagus there, and then we make a side cut. And practically, as I said, the last 75% of the cases are side to side anastomosis. Okay. So the point of stricture formation will not happen.
Sir, for a retrosternal route, I agree with what you are saying. The patient is having a native esophagus which is strictured in place. So you have an option of doing a side-to-side esophagocolonic anastomosis at the proximal end.
Yeah.
But does a route, because since you are saying that you have not used a natural route for colon, that is in place of esophagus, you have never resected the esophagus. In our experience, what we have found that if we are using a natural route, that is, if we are resecting the esophagus and taking the colon through the posterior mediastinum, it usually works better. It is functionally better. It is usually more distendable. It is more peristaltic activity is better. That is what we found. So therefore, we have again reverted back after doing some retrosternal route. We have again gone back to the same that we do a esophagectomy and do a posterior mediastinum for the colon to be used.
No, my question was that when you have used retrosternal route, what anastomosis you have done in the neck?
The retrosternal route always will be side to side anastomosis.
No, not necessarily. There also you can do end to side. You can always ligate the lower end of the esophagus and do. That is what we
usually we don't do it. So we do a side to side anastomosis.
Side to side. We have stopped doing that. So you're doing side to side. But
once you are resecting, then it will be end to side.
I'm not sure why they had.
Yeah, I don't. That's what I wanted to know from an expert, that since this was our experience, it is a very small experience.
One of the things is that when we take it through posterior mediastinum, the inlet of the thoracic inlet column is less. Yes, so that's a natural route.
Right.
So that is what I was asking Ashish, that we have to be very sure that when we create that retrosternal route, okay, we usually use those large abdominal pads to create that. So it should not be such that just the colon passes through and we should be happy. It should be wide open there, and that is what actually prevents the leak. If leak happens, then it certainly going to lead to dysphagia also, and it will also lead to difficulty in swallow. So next time you can try that make a little wider opening. People have suggested even sectioning the heads of the clavicle, but that is not necessary. We've never done that. But nice wide opening in the neck is extremely important, extremely important. And the incision that we give it in the neck, the hockey stick incision, it should cross the right sternocleidomastoid. It should cross.
Yeah.
It should not be just like a sphinctectomy or Oringer incision, and that it should cross, and you should have a nice wide opening there. Then you can try like that.
Actually, I agree. Inlet is a very important aspect when you're doing the retrosternal route. Now, there's a second aspect to it. When you're using a colon for a transposition, does it make a difference whether you are using the isoperistatic colon or you are using a antiperistaltic colon?
Should not, but usually we use isoperistatic. As I told, that the IC junction goes in the neck, and we leave behind a little bit of colon also there, 4-5 centimeters, redundant colon in the neck, because if there is a stricture formation which is very bad, the same colon is used for further widening the anastomosis.
Sometimes when you are not getting a good vascularity from the right colonic vessel, when you're using the left colonic vessel for the vascularity, or if you're using a middle colon for a vascularity and you take the distal colon into the neck, we need to say descending colon.
We are not using right, we're using left only.
Yeah, left. You're using left with the isoperistatic segment. That's what you want to say.
Left and transverse. Actually, it's a mid-transverse.
Yes, transverse is almost always used.
Yeah.
When you're using a left and transverse, it can be a antiperistaltic. That is, you're using the descending colon in the neck.
It can be. As I said, both
things. So will it make a difference? My question.
I'm not sure. The books say that it does not make, because we do always the isoperistaltic. In our experience, we are doing isoperistaltic only. But I don't think the other way around should make a difference. Should not. That will not produce the difficulty in swallowing.
Yes, I think the basic concept is that what students should know, that the colon does not act as a peristaltic segment in the chest. It is only as a conduit. It is just a tube to let the food come from what has been swallowed, going into the stomach or going into the jejunum distally when you are swallowing. So colon does not help in peristaltic activity. So almost always the patient has to be taught that he has to take whatever he eats or drinks in a sitting position only. He can't have swallowing when he's lying down or in a supine position. That will not work. This colon doesn't work in that condition.
Anand, my colleague wants to ask something.
Sir, my question different for the in case of isolated gastric injury, isolated corrosive gastric injury. In such patient, what will be the appropriate time for the definitive surgery?
6 months again.
6 months, because the literature sometimes they have written after 2 months in case of gastric outlet.
No, problem is if you try to do surgery little early, and if there is a progressive injury, and you already done the operation, and if later on some stricture happens, then it becomes a problem. Is it not? So it's always better that to wait so that the complete injury is documented, and then do the surgery. See, if a patient has a FJ, you see, FJ has to be there, is it not? Because 2 months the patient cannot be on some parental and all those things. So if the FJ is there, what is the hurry in operating?
Some reports from India, from the JP Institute,
this is the problem. Okay, if it doesn't happen, then it's good. But if it happens, the esophagus and the stomach both, okay, the injury can happen and it can progress for a long period of time. Usually the data says that after 6 months, usually it stabilizes. After that, you can know what is the extent of injury. My question is, if you've done, let's say, Bildroth-1 segmental resection after 2 months, and you find that later on the proximal stomach also becomes stricture, then what will you do? You'll have to do operate on the patient. So it's better to wait. As I said, once you have FJ, how the patient is trained to take through FJ, then wait. That's all. That's why I told here also. If the albumin is 2.5, wait. The date is fine. The weight also has to be seen, and it has 2 weights. The WEIGST and WEIT.
Okay, so thank you very much, Dr. Kate, for a very educative session on corrosive injury and management. We are already 10 minutes past, but just 2 or 3 small announcements. One, students, please email me again, vkkapoor.india@gmail.com. Just write ISO in the subject of the mail. So all mails received till midnight today, I will respond. Second, as Dr. Avinash has been requesting again and again, when you log in for this session, please identify yourself. Dell, Lenovo, iPhone, we may have to request you to discontinue. So please identify yourself. Also, thank you very much. All the third year students, I hope have responded to my request. I have made a list of all the third years. We will make a schedule. So it will be like a proper teaching program where there is a schedule. So you know which day you are going to present. If you can't present on that day, then you have to make an alternative arrangement with one of your colleagues. I will send the list of all third years to all third years so that you know each other. So if you can't present, then somebody else has to present. So I have already requested Dr. H. Ramesh has agreed to discuss surgery for chronic pancreatitis. So I think next week already somebody is allotted. That it goes on as it is. The following week, Abhishek, I think it's from Lucknow. I have already communicated that he should prepare surgery for chronic. So for operative surgery session, you have to prepare a slide showing indications, contraindications, preparation, little bit about technique and complications. And then the faculty will moderate. So it's not that the faculty will give a lecture. You have to make the presentation, faculty will only moderate. I may request them to show a small video to highlight some of the important steps of the procedure. But it has to be a student-based, kind of presentation. Our role is only to moderate these sessions. Okay. Thank you once again, Dr. Kate. Thank you very much.
It was a pleasure.
Thank you, Avinash, for your support, technical support once again. And thank you all the students. Okay.
Thanks a lot.
We will close the session.